we're recording. So, before we get started with blood and lymph, I'm getting a lot of questions about the community project, and I want to go over a couple things with that. So what's due at the end of this month for the community project will be your completed packet. Okay, so everybody's sections need to be complete, including the analysis and summary. The summary is basically just the summary of the statistics you collected. You can include how you got them if you want, anything that stands out to you, like there were no public libraries in the community or something like that. You know, but there are 5 daycares, there are whatever, okay? 1 hospital. And then the analysis section is going to be your critical thinking on that. So when you analyze it, I want you to think, well, if the community has no hospital and the patients have to drive, you know, so far away, or no cath lab at their hospital, then the patients have to drive so far away to get that care. And that may hurt the community's overall health. But the analysis is like your critical thinking about how the data that you collected in that section relates to the community's overall health. Okay, so like you know, public parks, if they don't have anywhere to go, maybe that can contribute to you know, obesity, right? Stuff like that. How many grocery stores do they have? And maybe that could contribute to the community's overall health, stuff like that. How many health departments, you know? And so the summary is just the data you collected, written down in paragraph form. The analysis is your critical thinking about what that data means for the health of the community, okay? Also on the community project, so what to do is your completed packet. And then the way that you choose your problem is you go into that completed packet and you look at the infectious disease statistics section and the mortality statistics section. That's going to be what infectious diseases are most prevalent in your community and what kills the most people in your community. And you can choose your problem from either one of these areas, but they need to be one of the top ones. Okay. So once you've figured out that problem, say HIV is a major infectious disease in your area, or say heart disease kills the most people in your area. Then what you're going to do, that's going to be your problem, and that is due to me. The group leader emails me that completed packet with the problem, and then the intervention, they also need to email to me. You don't have to email everything all done and written out, but I want like a 1-sentence statement of what your problem is, and I want a 1-sentence statement of the general intervention that you want to propose to do for your community. Okay, and how you do that is you go to like PubMed or any data research base. I think you can get to them from the library link on our website on PHCLR. And you're going to go and you're going to enter HIV/AIDS community interventions. You're going to enter heart failure community interventions, public health interventions for such and such. Okay, and you're going to search and you're going to see what other communities have done to address whatever problem you have that you've chosen. Okay, so I want your intervention in 1 statement, your problem in 1 statement, and your completed packets emailed to me by the end of this month. And then all the research you collect and all that kind of stuff, that'll be due at the very end. That's going to go into your presentation. So your research on your project, you know, how you're going to implement, how you would implement it, things like that. That's going to be due the following month. But I want to know your problem and your intervention because I want to make sure they're evidence-based, and I want to make sure you choose something good. That way you do well and your grade is good. Okay. Any questions on the community project? Thank you, Jasia. All right, if we have no questions on that, we'll get started on chapter 31, 11.1. All right, so we already kind of touched on the beginning of this chapter in the last lecture. So what we started with was we covered bone marrow aspiration at the very end. We covered our normal lab values, okay? I'm just going to reiterate those. Hematocrit around 40 to 55%. Hemoglobin, you know, about 12 to 18, depending on the gender. Neutrophils, 3,000 to 7,500. White blood cells, 5 to 10,000. platelets 150 to 450,000. T lymphocytes should be 60 to 80%, and white blood cells B lymphocytes 10 to 20%, or of your lymphocytes, sorry. And then there's one lab value we didn't talk about. It's called MCV, mean corpuscular volume. Okay, and so that's what we're going to talk about first, because that's going to help segue us into anemia. Okay, so get my little drawing app ready here. Okay, you should be able to see my screen. Okay. I'm trying to zoom in a little bit. Can you guys tell me how well you can see that little piece of paper that I had put up there? Is it big enough?
Yes, ma'am.
Thanks, Chris. All right. So, with anemia, I'm going to store it this way. Okay. All right. So with anemias, one way that we can divide up anemias is by the mean corpuscular volume. Okay. So MCV. And basically what that is it's a big fancy way of saying size of the red blood cell. Okay? Mean corpuscular volume. Your book calls it like something else other than mean corpuscular volume, but that's the medical abbreviation. I think your book simplifies it and does something else. But either way, anemia is characterized by low oxygen carrying capacity. Okay. Low O2. That's basically what anemia is. Okay. You can have like low hemoglobin, which can cause this. Okay. Or you can have low red blood cells, erythrocytes. Okay. It can be either one. So you can have enough red blood cells and just not enough hemoglobin on the red blood cell. Okay. Or you can have enough hemoglobin within the red blood cell, but you just don't have enough red blood cells. Okay? Remember, heme is that molecule in the blood cell that carries oxygen. Okay? This is just getting worse and worse. I don't know why this doesn't look good, but there we go. Okay. So all anemias kind of have the same signs and symptoms. Okay? All anemias have kind of the same signs and symptoms, no matter which one we're talking about. So the first one is going to be shortness of breath. Anybody tell me why?
Because of the low O2?
Exactly. Oh, I don't know why that's happening. Exactly. Low oxygen. Okay. So when you have a low amount of oxygen in your body and you're not getting enough oxygen to your tissues, your brain is going to tell your respiratory drive to increase. Okay? So you get shortness of breath or difficulty of breath. The next one is fatigue. Anybody guess why that is? I found that if you know why you get signs and symptoms, then it's really going to help you out with memorizing, because you won't have to memorize because you'll understand. But the reason you get fatigue and you're tired is because you need oxygen to make energy. Okay, your cells need oxygen. They don't have enough. They need you to conserve energy, so you get tired. The next thing is tachycardia. Because your cardiovascular system recognizes that you don't have enough oxygen in your body. And so what it tries to do is it tries to circulate the little oxygen that you do have in your blood around faster. Okay. And so the heart beats faster, so you get tachycardia. Tachypnea, kind of along the same lines of shortness of breath or dyspnea. Okay. So you get tachypnea. Dizziness. Anybody have a guess as to why dizziness occurs? Okay. Dizziness is because you're not getting enough oxygen to your brain. Okay. So you get orthostatic hypotension, which can cause dizziness because of the low oxygen level to your brain. And that's basically like dizziness when you stand up. Okay. Now, most anemias also have these clinical signs and symptoms. Okay. Most anemias are going to have cool, clammy skin because when you're low on oxygen, what the body does is it vasoconstricts and it tightens down all your vessels so that you can get the most blood possible to your heart, lungs, and brain, and you're not having wasted blood on your fingers or your toes or your skin. Okay, and so it wants to get the oxygen to the important areas, so it clamps down on your vessels. And so you'll have cool, clammy skin because your skin is not going to get as much blood as it normally does. Amenorrhea, which is no menstruation. You'll lose your period if you're a female within childbearing years. Acidosis in the body. You'll have pallor. You'll be pale. Right. You may have constipation. Okay. Anybody have a guess as to why that would be?
Because of like dehydration or fluid volume.
Yeah, that's one part of it because, your GI system pulls fluid in it so that you can have bowel movement. Another thing is, again, with the clamping down, so we want all of the essential organs like the heart, lungs, and brain to get all the blood. So your sympathetic nervous system is activated, and when that's activated, the body doesn't care whether or not you can make a bowel movement. It wants to get oxygen to the important areas of the body. So you may get constipated just because of a lack of blood flow to the GI system. Okay. And that can also cause nausea and decreased bowel sounds. Then you're going to have neurosymptoms and symptoms, okay, like difficulty concentrating. And that's because the brain isn't getting enough oxygen, okay? All right, so all right, guys, this thing's happening here. Okay. Usually this thing works really well. Okay, so we've gone over the signs and symptoms that every anemic usually has, okay? And so now we're going to go into where this MCV kind of comes in, okay? So anemia is essentially low O2, okay? Low oxygen. So the mean corpuscular volume, your book may have slightly different values, okay? And that's fine. You can learn the ones in the book if you want for the exam. If we give you any of these values, they're not going to be anywhere close to the normal range, okay? So, the book may teach you slightly something different. This is what I learned, okay? And that's fine if they're different. You can learn either one. So a normal MCV is 80 to 99, okay? That's normal. And remember we said the MCV generally is just the size of the red blood cell, okay? And so the way that we can divide up anemias is by their MCV, okay? So you can have a low MCV, and you can have a high MCV, which obviously low would be less than 80, Okay. And then high would be greater than 99. Okay. There are a couple of test questions on your test, and I'm going to tell you a few of the qualities of the red blood cell, like the MCV, and I want you to know which anemia I'm talking about based on the qualities that I give you. Okay. So if somebody has a low MCV, that's called microcytic. Just means their red blood cell is small. It's a fancy way of saying that. Okay. And if they have a high MCV, or microlytic, I'm sorry. Okay. If they have a high MCV, it's called macrolytic. Somebody may describe a red blood cell to you like it's hypochromic, which means it's pale, okay? And it's microlytic, which means it's small, okay? Or macrolytic, which means it's large. And then you'll need to know which anemias kind of fall in those categories, okay? So the first microcytic is iron deficiency. And we're going to go into each of these individually, but I'm just giving you kind of an overview chart so that you know how to divide them up in your head, okay? Sideroblastic is another one. We're not going to go over that one because it's not super common, and we're just going to do the common what you need to know for boards. But sideroblastic is a type that's microcytic, okay? Thalassemia, which we are going to go over. Okay. And then anemia of chronic disease. And it can actually be low or normal. Okay. Your macrolytic anemias are going to be your basically your nutrient deficiencies, okay? And so your B12 deficiency and your folate deficiency. Those are really the ones that are macrolytic. So if you want to just memorize macrolytic, and then you'll know the other ones are microlytic, that's fine. Okay. And then we went over the signs and symptoms of all anemias. Okay. So if a board's question gives you the patient comes in with a chief complaint of fatigue, their heart rate is 120, their respiratory rate is 35, and they're pale, you need to be thinking anemia, especially if it's in a teenage girl. It's pretty common in that population for them to have like an iron deficiency anemia because they're starting to menstruate. Okay. So that's how we divide up anemias, and that's kind of how we study them. All right. So the first one we're going to talk about is hypovolemic anemia. Okay. Also, really quick before we start on different types of anemia, I want to kind of give you a deeper anatomy of the red blood cell. Because I think it's important to understand that. All right. So when you have a red blood cell, it's like this. And the outside will be darker. And the inside will be kind of like paler. Okay. When you look at a red blood cell from the side, it's going to look like this. Kind of like a barbell. Okay. And then this is where your hemoglobin is. Okay. what makes up the shape of the red blood cell is all these protein chains, okay? And so when you look at it closer, you're going to see all these little proteins that make up the surface of the red blood cell, okay? And so we've got alpha chains. And they just create like a little meshwork, kind of like your, cotton t-shirts, right? They're like a meshwork of threads, and that's how this is too. And then you've got alpha 1 and alpha 2 chains, okay? And then you've got beta chains. You've got beta 1, beta 2. Okay? This is like the outside of the red blood cell, if you go really deep into the anatomy of it, okay? And the iron is located here. Okay? So the iron is kind of in the middle, kind of like there's no nucleus in a red blood cell, but the iron's carried in the middle of the red blood cell. Okay, and so your heme groups are on the outside. Okay. Your heme molecules that make up the hemoglobin are on the outside here. Okay, and so that's kind of the general anatomy, and that's going to be important later whenever we start learning about why each type of anemia occurs and what's going on with each one. Okay. Now we can go into our hypovolemic anemia. It's probably the easiest to understand. Hypovolemic anemia. Okay. What's going on in hypovolemic anemia is some sort of sudden blood loss. Actually, it doesn't have to be sudden. It can be chronic. You have sudden or chronic blood loss. Okay, that's what it means. Hypovolemic. That means if your blood pressure is low, hypovolemia. Okay, it's the same thing. So it's some kind of blood loss somewhere. Pretty frequent causes of this will be like trauma. Okay, like car accidents, stuff like that. Another frequent cause is going to be a GI bleed. Okay, that's something you can't see, but your patient may vomit blood. Your patient may complain of abdominal pressure. They may complain of black tarry stools. They usually come from stomach ulcers. Your alcoholics, a lot of the times, will have stomach ulcers or esophageal varices that will rupture internally. So they'll either vomit bright red blood or they'll have black tarry stools, and that should indicate to you that maybe they have an ulcer that's perforated. Alcohol is absorbed directly through the lining of the stomach, so it kind of tears up that lining a little bit. Okay. So hypovolemic anemia. Where are we at? Okay. But yeah, you just need to know it's from sudden blood loss. You identify it based on the situation, so based on vital signs. So your signs and symptoms of hypovolemic anemia are going to be low blood pressure, okay, pallor, obvious bleeding, internal bleeding. It's going to be like stool, vomiting blood. Okay. Other signs and symptoms, like they will also always include like the general signs and symptoms for anemia that I listed. Okay. They're going to be tachycardic. Your body's trying desperately to move the little bit of blood that they do have around to oxygenate the tissues. They're going to be pale, tachycardic, maybe diaphoretic. Okay. And then you're going to have a history that's consistent with like trauma, alcoholism, frequent ulcers, some sort of bleeding disorder, maybe irritable bowel disease like Crohn's or ulcerative colitis. Okay, those can also cause hypovolemic anemia. Let's see. That's probably all I need you to know about that. It's pretty straightforward. Treatment, stop the bleeding, right? Whether you do that through an endoscopy, so internal would be endoscopy, find the bleeding, okay? You're going to do frequent lab monitoring. And what I mean by frequent H&H is you're going to take their hemoglobin and hematocrit. Somebody that has this type of anemia, they're going to have a very low hemoglobin and hematocrit. Now, their cell morphology is going to be the same, right? It's going to be a normal MCV. It's going to be normal color, okay? Nothing's wrong with the cells. The fact that the problem is that we're losing blood. And so the H&H will be low, but normal morphology. Just means that's a fancy way of saying the blood cell will look normal, okay? So your treatments are to stop the bleeding, okay? We may also give them blood and blood products. We may give platelets. We may even give cryo if it's really bad. Cryoprecipitate is just concentrated clotting factors. We're going to replace fluids because, as we talked about earlier, 55% of your blood is plasma and 90% of that plasma is water. So they're going to need some water replacement too. Okay? We're going to monitor vital signs. Another test that can help us determine if it's hypovolemic anemia, we can do a fetal occult blood test. Okay? We can check their stool for blood. And then obviously we're going to monitor hemoglobin and hematocrit. All right, any questions on that one?
No, ma'am.
All right, cool. Let's move on. Iron deficiency anemia is going to be our next one. This is the most common cause of not have a sheet on iron deficiency. Oh well, we'll make one. Okay. Sorry, my computer's going slow for a second. Here we go. Next, we have iron deficiency anemia. So, you remember just a few minutes ago, I told you that the iron is stored here in the hemoglobin molecule, right? Right in the middle. Iron deficiency anemia is the most common cause of anemia. All right. So they like to put this one on boards a lot because it's common. Okay. So the pathology is iron is essential for the formation of heme. The heme portion of the hemoglobin. Okay. Y'all don't judge me, I can't spell. So iron this is a mineral that's essential for the formation of heme, for the hemoglobin molecule to carry the oxygen. Okay. There's something called protophorin, and protophorin reacts with iron through ferritokinase. Okay, these are just different proteins. This converts iron into heme. Okay, so iron is converted to heme through protein reactants. Hemoglobin, heme or hemoglobin carries oxygen. Okay. Thus, without the iron, the red blood cell cannot carry O2. Heme takes up most of the volume of a red blood cell, so without it, the red blood cell is small. Okay. And the reason I'm including that is because that means it's some microcytic anemia. Okay. So if you do a slide or a wet prep, of the patient's blood, like, stick their finger and look at it under a microscope, you're going to see that molecule's small. If you see right here, that's most of the hemoglobin. Okay. The small hypochromic part is on the inside. The major part is that hemoglobin on the outside, and so it's much bigger. All right. So let's go back to this. I keep hearing people like trying to get admitted to the class. There we go. I have ADHD, if y'all can't tell, so it's very distracting. Okay. So, causes. Are going to be a lack of, well, you can have it actually through blood loss, just like hypovolemic, okay? But how you're going to tell the difference is you're going to look at that red blood cell and it's going to be small compared to red blood cells. So that's how you're going to tell the difference between if it's hypovolemic or if it's iron deficiency, okay? So blood loss, maybe through a gastric ulcer, trauma, or menstruation, okay? You're going to have a lack of iron in the diet, okay? You cannot absorb the iron that you have in your diet. It's an absorption problem. Can anyone think of any diseases that would cause you to have trouble absorbing nutrients? What about alcoholism or any kind of disorder where you have frequent ulcers, right? Because then you can't absorb the iron, okay? And then pregnancy is also a common cause. And that's just because a pregnant woman needs more iron because your blood volume increases by 2/3 when you're pregnant, okay? So a pregnant woman just needs more iron than a non-pregnant woman or a non-pregnant person, okay? So how do we treat this? We treat it with iron. It's a replacement medication that you give. You give it with vitamin C. It's actually, iron absorbs the best way on an empty stomach. However, 100% of people will vomit if you give them iron on an empty stomach. So what we teach people, the next best thing is to give it with something acidic. So usually orange juice, okay? And that's almost always on boards in some form. You give iron with orange juice, okay? And so we replace the iron for them. It's also going to be normal for that patient to have some nausea with the iron, and then it's also going to be normal for that patient to have black stools. Now, they shouldn't be, super tarry or anything like that because that can indicate bleeding. But the iron pill itself, especially like if you've ever taken prenatals, it'll make your stools kind of black. And that's normal. Okay? Transfusion. You can give them a transfusion as a treatment. And then you can also just treat the cause. Okay? To treat whatever's going on up here, but usually it's diet related. Signs and symptoms are the same for all the anemias, but they will be microacidic, and that's kind of how we tell the difference. Okay, and then the patient will have low iron levels. You can draw that in a CBC. So that's another way to know which type of anemia you have. But then you have the same, signs and symptoms as all the anemias, which we went over earlier in this video. Okay. So diagnostic tests, labs you're going to take. You're going to take a hemoglobin and hematocrit lab. Okay. Which one do you think is going to be normal versus low? You take a hemoglobin and a hematocrit. What do you guys think that the results will be for iron deficiency anemia?
Hematocrit.
Mm-hmm. Yeah, so hemoglobin will definitely be low, right? Because you can't make the heme at all without iron, okay? So there'll be low hemoglobin. And then the hematocrit will also be low because hematocrit is just the percent of red blood cells that are in your blood. And if you can't make red blood cells successfully, are you going to have a high percent of red blood cells? Probably not. Okay. So they'll have low ferritin, which is our, it's like the lab that we draw to look for iron. Okay. They're going to have, the MCV is going to be low or microacidic. Okay. The TICB is a lab that's going to be high. And what TICB is iron binding. Okay. Transferrin iron binding. It's a protein that the body produces to help you bind to iron when you take it in from your diet. And so what the body thinks whenever you don't have enough iron, you can't make enough heme, is that, oh, well, we're just not absorbing iron well enough. So we need to put out more of this iron binding component or protein so that we can bind to all the iron that our body is eating. And so that'll be really high because the body kind of cranks up. It's trying to bind to as much iron as it possibly can from the diet. Okay. And then they will be hypochromic. And what that means is just the color of the red blood cell will be pale. And that's because heme gives red blood cell its dark green color. And if you can't make heme because you don't have enough iron, then the red blood cell is going to be pale looking. Okay. Let's see. Patient education. Increase iron in the diet. Okay. Okay. With vitamin C, because really it does take on empty stomach, but they will vomit. It causes nausea or black stool. Okay. Can't take antacids 2 hours before or 2 hours after the iron because the iron will not absorb. What antacids do is they create a nice little coating around your stomach that doesn't allow it to absorb anything. Okay. And so you can't take antacids with almost any medications, but especially iron. If it's a liquid, you need to drink through a straw and dilute it because iron will stain your teeth. Okay? That's especially important for children. So whenever we have an iron deficiency anemia child, we need to make sure to teach the parents because they can't take pills, right? So their preparations are always liquid. So we need to make sure we teach the parents, dilute it in some orange juice and drink through a straw. Okay. Like I said, you may have green, dark, black stools. And then your nursing considerations, you use the Z-Track method. Okay. And when you give iron, it can be, what happened there? Nursing considerations whenever you give the medication. It can be PO, IM, or liquid. So it can be a PO tab, IM injection, or liquid form. You want to use the Z-Track if it's an IM. It helps decrease the amount that will leak out of the muscle. Okay. A good description of the Z-Track method is here. Let's see. Cover everything on the study guide. Oh, a good diet education is they want to increase their protein in their diet. That's going to be things like eggs, meat, okay? Nuts have a lot of protein in them. And then let's see, don't take antacids with them. Make sure you know that. What about this question? This is kind of an odd question, but if a lot of the times toddlers will come in and the parent's chief complaint will be fatigue, okay? And then you take an H&H, and the H&H is low, and you look at the red blood cell, and it's microcytic and hypochromic, and so you think, okay, well, the patient probably has iron deficiency anemia. What are some things you should ask the parents about the child's diet if they're toddler age? Anybody have an idea? Bottle feeding or breastfeeding. Okay, how much milk is that child? Right. It's important to recognize that children need protein. Okay. And so if they're still drinking breast milk or if they're still drinking formula milk, it's important for you as the nurse to recognize that that might be a cause, okay, of iron deficiency anemia. Because they're not getting any protein in their diet. Also, what kind of people should you think may be at risk for this if we get iron from protein?
Elderly.
What? What's it? Say that again. Okay. Vegetarians, right? Vegetarians or vegans are going to be at high risk for a couple of different types of anemias, and this is one of them, okay, iron deficiency anemia. Also, you may have the parent or child or person, whoever's got the anemia, complaining of pica. And what that is that's when you have an urge to eat something that's not food. Okay, usually it's like dirt or pennies, and that's because you need the minerals in the dirt. There's a lot of iron in dirt. Or the minerals like the iron and the copper from the pennies. People actually have cravings for those things, and that's what that is. It's pica, usually due to an iron deficiency. Okay. Questions? Okay, on to the next one then. All right. There we go. All right. Let's see. Sickle cell. That's a fun one. Okay. Sickle cell anemia. This one's all over boards. I would say iron deficiency and sickle cell are the two most common ones, okay, on your board examinations. So, sickle cell anemia. All right. So what this happens, it's genetic. It's inherited. It's autosomal recessive, which means one parent has to carry it. And what it is the hemoglobin S gene. It's an extra gene. So remember when we talked about those protein strands right here? Okay, so this is why partly that's important. those alpha and beta strands. Okay, well, instead of having the normal alpha and beta strands, one of the beta strands that's supposed to be there is actually a hemoglobin S strand. It's something that you're not supposed to have. It's extra. It's abnormal. Okay, and so you have one of those strands that make up the outside of the red blood cell is wrong. Okay, it's typically in African American population. So I have had one white Caucasian patient with sickle cell anemia, but she must have had some sort of lineage, some African American, grandparent, great grandparent, somewhere along the line, because it's typically only found in African American and Mediterranean populations. Okay, and they can live a normal life, but when their red blood cells are stressed or they're not exposed to enough oxygen, okay, which means like their capillaries and stuff, they don't have enough oxygen from the lungs, they crystallize and take on a sickle shape. And so what happens essentially is all these proteins right here, they're hydrophilic, okay? And what that means is that they don't mind water, okay? Philic means love, phobic means scared or hate or afraid of, okay? So, sorry. When you have proteins that are hydrophilic, that's fine because your blood is mostly water, right? And it doesn't really cause any problems. But that hemoglobin S gene that I was telling you guys about that the sickle cell people have, that protein is hydrophobic, okay? And so what happens is you have your normal red blood cell and you have your normal proteins, and that's fine. But when you're exposed to low oxygen and you have sickle cell, it activates that hemoglobin S gene. And since that gene is hydrophobic, doesn't like water, what ends up happening is the normal shape here, which is fine with water, that shape of the red blood cell, because remember I told you these proteins are on the outside, they make up its shape, okay? Kind of like a balloon has water, and the balloon makes up the shape of whatever is inside the balloon. So what will happen is that red blood cell will be exposed to low oxygen concentrations, and since that hemoglobin S gene is hydrophobic, it will kind of bend away from the water in the blood. And what that does is it causes this sickle shape to happen. Okay, so it kind of looks like this compared to this. So when that S gene gets low oxygen, it activates, it kind of just, it's phobic, it doesn't want the water, it wants to get away from the water, and so it changes the shape of the outside of the red blood cell. And the red blood cells are the exact shape that they need to be. They are the biggest thing that can get through a capillary bed, okay? And if they can't get through the capillary bed, what happens is they will clot up the capillary bed. So a normal capillary bed's a circle and you just go through it and you're fine. But the sickle cells get caught on the capillary bed and they kind of clot it up. And so these patients get blood clots everywhere. Okay. So that's kind of what sickle cell, what's going on with that. I'm going to actually use this sheet because I like it better. Okay. It has the same information, just in a different way. And so what happens is they clump up, they cause clotting and oxygenation problems, because if you've got blood clots at your capillary beds, you're not going to be able to get normal red blood cells in and out and exchange oxygen, so their organs and their tissues don't get oxygen. Okay. And what happens is they have a really high risk of stroke. Their life expectancy is only like 30 or 40 years old because they have so many complications with this. They can go into kidney failure because the kidneys really don't like blood clots. Okay. They can have a heart attack and MI because in the coronary arteries, you can get these blood clots all over the body. Okay. Anywhere there's a capillary bed, you get a blood clot. Acute chest syndrome is part of sickle cell. It's just like blood clots clotting up the pulmonary and the coronary arteries. And then pulmonary hypertension, that's because of clotting in the pulmonary system. And so the blood kind of backs up and the pressure gets really high. All right. So what are you going to see in these people? Okay, nursing assessment. You're going to see pain. Pain is the main symptom of sickle cell anemia. A lot of these patients take a lot of pain medications every day. Okay, they're in pain most of the times in their lives. Okay, the things that can cause a sickle cell crisis. So normally, I mean, they can live a normal life, but as soon as they get exposed to anything that causes them to have less oxygen, that's when this clotting up and this sickling starts happening. Okay. And so it's very painful. Imagine, when you're running and maybe your side starts to hurt because that lactic acid is building up in your muscle and your muscle isn't getting enough oxygen. Imagine that all over your body. Okay, and that's how sickle cell feels. It's very painful. And so they take high dose pain medications. They're frequent flyers in the ER. Because things that can cause a sickle cell crisis are like dehydration. So whenever you have a patient, you need to teach them to drink at least 2 liters of fluid per day. Okay. Colds, coughs, colds, any kind of viral or bacterial problem in the body, it's going to cause you to have low oxygen because your metabolism's way up trying to fight that. Okay. And you're using more oxygen than normal. So you want to try to teach them to avoid getting infections, avoid being around sick people, things like that. They need all their vaccines. It's very important for your pediatric sickle cell patients. They get their vaccines early and they get more than most people. Okay. Also in high altitudes. So like if you go somewhere like Denver, today is actually my wedding anniversary. And last year for my anniversary, we went to Denver, Colorado. And I kind of felt a little bit sick the first couple of days. And what it was is it's altitude sickness because it's so high. And that's why you have these people who live in like the Andes Mountains and the Himalayas who can just truck up the mountain and down the mountain carrying all the hiker stuff because they live there. And so when you live in a high altitude place like Denver or the Himalayas, your body actually makes more red blood cells. And so this is why the Olympic Training Center is in Denver, is because the more red blood cells you have, the more oxygen you can carry. The more oxygen you can carry, the higher performing your body's going to be under stress. And so but what this means for sickle cell people is that they really don't need to go to places with low oxygen concentration in the air, like Denver or the Himalayas or anywhere that's really high above sea level. When they go to these high elevation places, they're going to get into sickle cell crisis because they don't have as much oxygen in the air that they're breathing in as we do where we live. And that low oxygen concentration is going to cause a sickle cell crisis. But those are the most frequent causes: high elevation, dehydration, illness. And I mean, honestly, like probably half of you are dehydrated right now and don't know it. I mean, it is really hard for these people to prevent the crisis. And so a lot of ER nurses get very frustrated with the frequent flyers because they need high doses of pain medication. Almost no amount is ever enough. It's very painful disease, okay? And then they think, well, if the patient just would prevent the crisis, this wouldn't happen. Well, think about how often you're dehydrated. Think about how often you get sick, how often you're stressed. Even stress can cause a sickle cell crisis. It's like just being stressed that you have an exam, okay? Because that's going to cause low oxygen to your tissues. Because your oxygen, when your fight or flight kicks in, oxygen goes to your heart, lungs, and brain. And so when you get low oxygen in the tissues, you still start to sickling up. So even just normal life stress. And so it's very hard for these patients to prevent a crisis. And it's very hard for caregivers to understand that, like, put yourself in their shoes. It's very difficult for them. Okay. But anyway, so what are you going to see? The signs and symptoms. The signs and symptoms, as always, have a lot to do with the cause. Okay? You're going to see pulmonary hypertension because of the clotting in the lungs, acute chest syndrome because of the blood clotting, intense pain and swelling of joints because of blood clotting and the acidosis that's building up because your body can't get rid of its CO2. Not only can it not get oxygen to the tissues, but it can't get CO2 from the tissues, which causes an acid to build up, and it's very painful. When they have sex, that can also cause a sickle cell crisis because it activates your fight or flight syndrome. And then if they do have sex, then they can get what's called priapism. Okay. A priapism is a prolonged, very painful erection. It's a really common reason sickle cell patients will go to the ER. Okay. They'll have tachycardia, just like every anemia, because the heart's working really hard trying to pump what oxygen we do have around. Their kidneys, they'll go into renal failure because of the clotting. And then they may have an enlarged heart as well. So these patients are very sick. They're actually doing an experimental treatment right now in which they have taken apart the HIV virus, right? And so what they've done is the HIV virus is very effective in changing the DNA of your cells. Okay? And so what they've done is they've taken the HIV part out of the HIV virus, and they've injected a normal hemoglobin DNA strand into that instead of the virus, and they are giving it to people. So they are killing their immune system and then giving them this altered HIV virus with the normal hemoglobin in there. And what we find is happening is the patients are able to then start their DNA of their cells change, and they are able to start making normal red blood cells that don't sickle. And so that's kind of a cool experimental treatment, but that's not on your test. It's just a cool thing to know. So your priority interventions for your sickle cell patient, you can use the mnemonic PARMS. Painful is your mnemonic for your signs and symptoms. PARMS is going to be for your intervention, what you do. So the very first thing that you're going to do is give fluids. Now the patient is going to want you to give them pain medicine, right? Their priority is pain. That patient's in a lot of pain, but that is not your priority. And boards will try to trick you. They will say your patient's pain is a 10 out of 10 and they are screaming. What do you do? And one of the options is going to be administer hydromorphone or administer, morphine or whatever. That's not the right answer, guys. It's fluids. They need fluids. Okay. That blood volume up. You've got to solve the problem of dehydration and sickling before you can really address the symptom of pain. They need oxygen. They need high levels of oxygen. They need rest. Okay. Like a child with sickle cell crisis should not be in a day room playing with other children. Okay. A child in sickle cell crisis needs to be in their hospital bed watching a movie. Okay. You can also give them medications for pain after the fluids and the oxygen. Okay. And then, another thing that causes sickle cell crisis is being very cold. It's cold outside. It's very cold, so make sure you keep them warm and stuff like that. Okay. Medications. So they take folic acid every day. Remember I said folic acid helps you make that heme part of the hemoglobin? Okay, well, they have to make a lot more, and their body has to destroy a lot more red blood cells than most people. Okay, you will see, just like we talked earlier about the jaundice and the bilirubin in the previous lecture, these patients will often have yellow eyes. They'll be in liver failure from trying to get rid of all these sickled trash red blood cells. So in order to make good new red blood cells, they need folic acid, so they have to take it every day. You also want to do pain management, okay, and heat to vasodilate and open up those clotted areas. Hydroxyurea is a medication for them. It decreases the formation of sickling cells. Aspirin, it's an antiplatelet to kind of keep those clots from being too bad. Arginine is a pulmonary vasodilator that inhibits sickle cells in the lungs. Vasopressin for blood pressure and for kidneys. NSAIDs, again, mostly for their anti-inflammatory and platelet function. Oxygen, obviously, because if you can increase the oxygen, their cells will stop sickling. And then blood transfusions is pretty common as well. Okay. You don't give a sickle cell patient Demerol because it can cause seizures, so that's the only pain medication they can't have. Any other pain medication is fine. Okay. We've kind of been talking about a sickle cell crisis this whole time. You can have 3 different types of crises. The most common is vaso-occlusive, and that's really all I want you guys to know about. Okay, where the sickle cells have caught up in the capillary beds and causing clots, basically. Okay, so labs you can do. So there's called a SickleDex lab, and you can do that in clinic. It's just like a finger stick, and it looks for that hemoglobin S gene. So if mom or dad has it and they have a baby, they may do a SickleDex lab when the baby's newborn to find out if they have that hemoglobin S gene to watch for it. You're gonna have a hemoglobin labs. Electrophoresis will tell them if the cell has that gene to sickle. Okay, a CBC, ferritin levels for iron to see if they're taking enough iron. Hemoglobin and hematocrit are like every 2 hours when they're in the hospital. And then a blood smear will show a red blood cell with a sickled shape with it. They're in crisis. Nursing care, like I said, fluids, oxygen, pain management, blood transfusions, treat electrolyte imbalances. Okay. Any questions on sickle cell? Most of your exam questions are related to teaching the sickle cell, like avoid high altitudes and stuff like that. Interventions for somebody in a vaso-occlusive crisis. Normal range of folic acid is 1.8 to 9. Okay. And normal range of B12 is 200 to 900. Those are also important to know for your test. So when you take a folate level, it should be 1.8 to 9. And then B12 should be 200 to 900. That's not about sickle cell, that's just in general. But most of yours are patient teaching, which patients are at higher risk and should be African American. Okay. Sickle cell doesn't have anything to do with diet, doesn't have anything to do with pregnancy, didn't have anything to do with some of those things that the other ones do. Okay. Sickle cell is also the only type of anemia that will have like leg ulcers and blood clots. Okay. Most of the other anemias don't cause blood clotting. So that's something that's unique to sickle cell, and that can help you pinpoint that the answer is sickle cell. All right, if there's no questions, I'm going to the next one.
Can you repeat the last part that you said that what is special about sickle cell anemia?
Yeah, so you remember how I talked about how the sickled cells will clot up in the capillary bed, and that causes blood clots? Well, when you have that happening all the time, you're not going to get oxygen to your skin, and that's going to cause ulcers, particularly leg ulcers. And so that's something that can help you differentiate sickle cell from other types of anemias on a test, is because they'll have leg ulcers with sickle cell. Okay.
Thank you.
You're welcome. All right. Next one we got hemolytic anemia. Okay. Sorry, I need an adjustment. All right. Hemolytic anemia is, remember how we talked about giving the right blood? Hemolytic anemia occurs when you give the wrong blood. And it occurs in a newborn if mom doesn't get RhoGAM. Okay. Slide for hemolytic anemia. I might not, it's not super common. Okay. But hemolytic anemia is going to happen when antibodies are attacking the blood. Okay. And so usually it's because of an incorrect blood transfusion. So that's where I have all this written down. I didn't write out a special thing for hemolytic anemia because it just kind of goes in with that blood transfusion sheet, which, by the way, I did put that for you guys. So if you go into your med-surg course and you go into your resources, all the things that I used in lecture today, I put up here. Okay. And so this is the one right here that I'm referring to. All right. So this is what happens whenever you have hemolytic anemia. All right. These 4 things here. And so you'll have the immediate transfusion reaction. And basically, since your immune system is destroying your red blood cells, are you going to have anything that carries oxygen around? No, right? So your body immediately gets in an oxygen deficit state, which causes most of these symptoms. Okay, chills, diaphoresis, aches, pains, rash. The rash, hives, itching, and swelling, that comes from your immune system, your granulocyte immune system. They kind of release all those reaction things. The rapid thready pulse comes from the heart trying to circulate as much blood as it can that has oxygen. Dyspnea because of low oxygen, cough because of low oxygen, wheezing. Fluid tends to back up in the pulmonary system. Circulatory overload. So a hemolytic reaction can occur if you give blood too fast. So we usually give blood at like 50 mils an hour for the first 15 minutes. And that's because you can get this, even if it's the right kind of blood, you can get an overload in the blood system by putting it in too fast. So septicemia. So if somebody's given blood that has like a bacteria or virus in it, That will make them very sick. And then iron overload. Once you give somebody, like I had a pregnant patient once, and she had an abruption, okay? And we couldn't fly her out to a high level acuity center. It was a small town ICU, like a 12 bed, never did art lines or anything at all, very high level. And so after about her 10th blood transfusion, because she was bleeding out so fast, she started to get this reaction. It was a hemolytic reaction. And she started to get really sick. And chills, hives, the whole thing. And so that was a hemolytic blood reaction. So we have one question on this. It's select all that apply. And it's like, what steps do you take when your patient starts having a blood transfusion reaction? Sorry, one of you are texting me. Okay. So that's all I want to tell you about hemolytic anemia. Now let's talk about thalassemia. The book calls it something weird. Anybody have the book open? I don't like the way that your book refers to thalassemia. Like, it might be Cooley's anemia. Does that sound familiar to you guys who have read the chapter?
Yes, ma'am.
Cooley's anemia. Yeah. Okay. So we're done with sickle cell. So I learned it as thalassemia. There's a couple different types of thalassemia. Cooley's anemia is just one type. So thalassemia. They basically just want you to know the assessment findings on my study guide, but I've got a little more than that to tell you about it. All right, so thalassemia occurs. So if you look at the bottom of your study guide, it's either chapter 31 or chapter 32. It's got that I want you to know different types of patients and what kind of anemia they're at risk for. So if you look at number 14 on the study guide, it's chapter 31. It says pregnant women, right? So one of theirs is iron deficiency. Vegetarians and vegans, that's going to be like your pernicious, which we're about to talk about, and your iron deficiency, okay? The Mediterranean descent is what people with thalassemia have, okay? So it's a gene. Okay. So instead of having the alpha and beta strands, remember that I wrote out right here? You've got the alpha and beta strands. You've got beta strands actually 1 through 4 and alpha strands 1 through 2. And so what thalassemia is an absence of some of these protein strands. And how bad the thalassemia is depends on how many protein strands are absent, okay? And so if you've got like 1 or 2, you could have Cooley's anemia. It's fairly mild. You may not even identify it right away. The kid may come in with fatigue, failure to thrive. They may be, a couple months old. And they're just not growing, and they're really tired all the time. And so, and they're not feeding as much because feeding takes energy and work. And if you don't have enough oxygen, then you're not going to want to do anything, including feed. And so this will be like Cooley's anemia, okay? Now, you can actually have worse cases of thalassemia where all of the beta strands, like 3 of the beta strands are replaced, or even 4. And that results in fetal erythroblastosis and fetal hydrops. Okay? These are diseases that you'll learn more about in your newborn section. I'm not going to test you over newborn diseases. But thalassemias, I am going to ask you about an infant on that one because it's identified. It's usually identified in the first 2 to 4 months of life. So it's not something that adults are going to come in and get diagnosed with. Okay? But thalassemia is when those beta chains are gone off the hemoglobin proteins that make up or not the hemoglobin, the proteins that make up the red blood cell. Okay. And so when that happens, you kind of get this loose, yucky, floppy red blood cell. Okay, it has no shape to it because these proteins make up the shape of the red blood cell. So that's why we call it a macrocytic. The blood cell is too big. Okay, it's depending on how many protein strands are missing, it may carry some, little, or no oxygen. Okay, because if you can't make up the heme with those protein strands, then you're not going to be able to have a functioning hemoglobin on that red blood cell. And so the ones that are missing 3 and 4 strands, those are not compatible with life. They usually die. It's inherited, so you can get your genes tested and see if you have the genes for thalassemia before you have a baby. But these patients, if they're missing 3 or 4 beta strands, they can't live. It's pretty sad. It's their blood cells are just like kind of like jelly. They don't have a job. They can't feed their capillary beds. They can't give tissues any oxygen. So you can imagine how that works out with the baby. Some of them die in utero. Some are born a couple of days and then they pass away. But Cooley's anemia is the one that you can live with. And so that's why your book is kind of asking you about that one. Cooley's anemia has all the same signs and symptoms as all the other anemias. Fatigue, shortness of breath, the babies, it's identified in infancy. And usually if the test question gives you an age, that age is important, especially on boards, okay? So if the test question says it's a baby, they're wanting you to know something about either the pathology of that disease or communicating with children, or there's a reason that age is given in there, okay? And it's not just assumed as an adult. Well, thalassemia is one of those because you identify it within the first 2 to 4 months of life, okay? It has all the same signs and symptoms. When you look at the red blood cell, there's basically no shape to it, okay? So we call it macrocytic. It's just kind of floppy and loose, and it's because it's missing its protein chains. But the signs and symptoms are the same as all the other anemias. But what's unique is you need to know it's Mediterranean descent, okay? And it's identified early in childhood, and those should be enough to give you hints on test questions about thalassemia. But there's not a lot clinically that's any different than any other type of anemia. The way you treat it, usually a stem cell transplant or frequent transfusions. Okay, there's no real medicine. They have to take folate and B12 and iron because they have to make more red blood cells than normal. 1 second. This is Brandy. I'm sorry. I'm in my office giving a lecture. Okay, where are you at? Up in the business office? Or at the very front desk? Okay, I'll be there in a second. Thanks. That's probably a good place to take a break. That's all I want you to know about thalassemia. Let's take like a 5-minute break because apparently there's something up front for me, so I'll be back. You guys take 5 or 10 minutes. It's 2:22, so we'll start back at 2:30.